you very much. So first of all, I would like to congratulate the organizers on this nice meeting and thank you for the invitation. So I'll talk to you about our work on functional precision medicine. So you can imagine that you are standing on the floor and you're holding this egg in your hand and you would like to find out what happens if you drop it to the floor. Does it break or not? So you can take different approaches to try to model this. Maybe you can measure the distance from the egg to the floor. You can look at the size of the egg, maybe the thickness of the shell. But you would get the correct answer faster if you simply drop it and see what happens. Now you can ask the same question for a cancer cell. So you would like to find out what therapies would be effective for this cancer cell. Again, you can make different models. Maybe you want to know what type of cancer it is, what mutations are present in the cells, and so on. Another option would be to simply treat the cells with different drugs and see which ones are effective. So the model that we are using is chronic lymphocytic leukemia. It's the most common form of leukemia in the Western countries. The median age is 72 years, so it mainly affects the elderly population, and more men than females are diagnosed with this cancer. And actually the recommendation is that you do not treat the cancer upon diagnosis, you wait until it becomes symptomatic. But the disease is very heterogeneous, so some patients may never need treatment, while others have a very aggressive disease and will need treatment shortly after diagnosis. And over the last years, we have had a great development in treatment of this cancer. So we have gotten new targeted therapies, and I'll go through those briefly. So CLL is a cancer of the B cells. So this shows the surface of the B cell with the B cell receptor here. So this is the master regulator of the B cells. When you have a activation of this receptor, you initiate the signaling cascade, which again tells the cell to proliferate, or it gives survival signals and so on. So indicated here in blue are different proteins that are found inside the cell. So when the receptor is activated, it will lead to activation of these proteins by phosphorylating them. And this is a cascade that is going between these different proteins here. And it's known that some of these proteins are important for giving proliferation and survival signals to the cancer cell. And they are upregulated in cancer cells compared to normal cells. So these have been identified as drug targets. And now for CLL, we have different BTK inhibitors, PI3 kinase inhibitor, and the BCL2 antagonist venetoclax that are all approved for treatment. So this is a very nice development, but still we have the challenge of resistance to these therapies. So most CLL patients, they will have a very good initial response to these targeted therapies, but then it varies how durable the response is and if the patients develop resistance. So what options do we have for patients that develop resistance? And that's where we hope that we can contribute with our research. So our approach is to isolate the CLL cells from blood samples, and then we treat them with different drugs, and we see if they are killing the CLL cells or not. And the hypothesis is that those cells that are effective outside of the body will also be effective in the patient. So here are some more details of how we are doing these experiments. So when the CLL cells are taken out of their natural microenvironment in the blood, they rapidly undergo spontaneous apoptosis, so they are not very happy. So in order to be able to do these experiments, we need to mimic the tumor microenvironment in the lab. And for this, we have developed an assay where we culture the CLL cells with fibroblasts that express different growth factors to stimulate survival signals in the CLL cells. And we have found that it's sufficient to have this co-culture for 24 hours. And then we can, again, separate the CLL cells from the fibroblasts, and they will survive in culture. So this is what we do. We continue with the CLL cells, and we expose them to a library of different drugs. And the library is printed in 384 well plate format. So we dispense the CLL cells into these wells. And we are testing both single agents and drug combinations, and all at 5 different concentrations. So then we leave the cells with these drugs for 3 days, and then we measure the effect on cell viability. And this we do by looking at the ATP level in the cell. So if the cells are dying, they stop to produce ATP. And the ATP is detected with a reagent that will produce a light signal. So live cells will give a strong signal while the dead cells don't give any signal. So since we are testing the drug at different concentration, we will see a dose response. So let me first present one patient case for you. So this is a CLL patient that presented with 2 poor prognostic factors. She had unmutated IGVH and a TP53 mutation. And shown here is a timeline on years since her diagnosis. And as you can see, she needed the first treatment 3 years after diagnosis. And at this time, she was given chemoimmunotherapy. And she had a complete response and undetectable MRD. So you see that she was doing well for several years after treatment, but then the cancer came back. And then she was again given chemotherapy, but she did not respond. And luckily, this was just at the time when the new targeted therapies were available in Norway. So she could then receive the BTK inhibitor ibrutinib. And these targeted therapies, they are given until they stop working. So as you can see, she was on this therapy for a few years. But then again, the disease came back. So then she was changed to PI3 kinase inhibitor, idelalisib. But unfortunately, she had adverse events and the therapy had to be stopped. So then there was only one option left, which is the BCL2 antagonist venetoclax. And this was effective, but only for about a year. And then she had progressive disease again. So now she had spent all the treatment options that are available in Norway, and it was not clear what to do for her anymore. So then, in collaboration with the treating physician, we took a blood sample and we performed a drug sensitivity screen on her cells. And then what we found was that the cells were still responding to a combination of venetoclax and a PI3 kinase inhibitor. So in this graph, we show the cell viability here on the y-axis and the increasing drug concentration on the x-axis. So you see that the different treatments are killing the cells in a concentration-dependent manner. And since venetoclax and idelalisib are treatments that are available in Norway, it was decided to give her this as a therapy. And encouragingly, she was responding. So here are the cell counts of her different blood cells. So you see that the leukocytes, which include the tumor cells, they are going down on when she was on treatment, while the other cells are going up. So basically all the cell counts are normalizing, indicating that she was responding to the treatment. Then we had a second patient, and he also presented with the same poor prognostic markers, unmutated IGVH and a TP53 mutation. And again, he has been treated with all the targeted therapies. The last one was venetoclax, where he responded very well for several years. But as always happens, he also had a progression. And then the physician contacted me and asked if we could perform a drug sensitivity screen. So we collected the blood sample from him. And we could confirm that the sensitivity to venetoclax, which he had been treated with, was now lower in the cells when he had progressive disease compared to before he started on this treatment. And in general, we saw that there was very low sensitivity to any drug in his cancer cells, with the exception of these therapies shown here. So again, you see cell viability on this axis and then increasing drug concentration here. So we found 4 therapies that the cells responded to. They were 2 proteasome inhibitors and 2 HDAC inhibitors. And based on these findings, the physician decided to start him on this proteasome ixazomib. And the patient is actually responding and slowly doing better. So this is very encouraging. So based on this, it may seem that ex vivo drug testing can be used to guide the treatment of CLL patients. And this approach has already been validated on aggressive hematological cancers in a trial called EXALT. So then I would like to show you some other study that we are doing in the lab. So as I showed you, the PI3 kinase inhibitor is one class of drugs that have been approved for CLL. And currently there are 2 PI3 kinase inhibitors approved. And the first one was idelalisib, and then the second one is duvelisib. So PI3 kinase, the catalytic subunit of PI3 kinase exists in 4 isoforms, alpha, beta, gamma, and delta, where gamma and delta are only expressed in leukocytes, and alpha and beta are ubiquitously expressed. So we wanted to see if there are differences between how these inhibitors that have different specificity behave in CLL cells. So we first look at the activity on the PI3 kinase signaling. So here we look at the protein downstream of PI3 kinase called S6 ribosomal protein. And again, you have a concentration on this axis, and each line indicates one drug. So as expected, we see that they all inhibit cell signaling. And this has been quantified here for 2 proteins downstream of PI3 kinase. And what we could see was that the PAN inhibitors, those inhibitors that inhibit all isoforms, are most active. In the same experiments, we also looked at the marker for apoptosis or cell death, which is called cleaved caspase 3. Again, the cells were only treated for 30 minutes, and at this short time point, the PI3 kinase inhibitors did not induce cell death. But venetoclax, which is the BCL2 inhibitor, you can see it induces apoptosis, and interestingly, the combined treatment of venetoclax and a PI3 kinase inhibitor has an additive effect. So to see if this effect was synergistic, we analyzed this data with the online tool called Synergy Finder, developed by Tero Aitokalio and his team. And with this tool, we can get the full response matrix as shown here. So this axis shows, again, different drug concentrations. And the red areas indicate synergy. And when we quantified this, we could see that for all the combinations between venetoclax and the 10 different PI3 kinase inhibitors, we could find synergy. So we have 2 PI3 kinase inhibitors available for CLL. And the question is, if the patient develops resistance towards one PI3 kinase inhibitor, can you still treat it with another PI3 kinase inhibitor with a different activity? So this has been shown for BTK inhibitors, where we also have 2 different inhibitors available for CLL. When the patients stop responding to the first one, they may still benefit from the second one. So to test this, we studied the cell line model that we have received from Francesco Bertoni in Switzerland, where they developed idelalisib resistant cells. And again, we performed the drug sensitivity screen, and shown here is the drug sensitivity score. So higher score means higher sensitivity. And as expected, we see that the resistant cell line shows lower sensitivity to the PI3 kinase inhibitors compared to the parent cell line. But interestingly, we see that it maintains quite good response to the PAN inhibitors. And this was also confirmed in the second lymphoma cell line, which is also resistant to idelalisib. So it seems that there is still some sensitivity to PAN inhibitors in the isoform-specific resistant cell line. So then if you remember this patient that we found could still be treated with idelalisib plus venetoclax, even though she was resistant to both idelalisib and venetoclax single agents. We collected blood samples from her both before the treatment of the combination, during treatment, and after treatment. And now we performed again the same drug sensitivity screens. And we could actually see that the cells remain sensitivity towards these pan-PI3 kinase inhibitors. So confirming the experiments that we saw on the cell lines. And we also had access to another small cohort of idelalisib resistant patients. So from these patients, samples were taken before treatment with idelalisib while they were responding to idelalisib, and then they had become resistant to idelalisib. And again, we see that they remain sensitivity to these pan-PI3 kinase inhibitors. So all these, although we only have data on few patients, this suggests that the idelalisib resistant lymphoma and CLL remain sensitive to pan inhibitors. And we have also shown that CLL cells show distinct sensitivity to pan inhibitors and isoform selective PI3 kinase inhibitors. And we see synergy between PI3 kinase inhibitors and the BCL2 antagonist venetoclax. So we have received funding from the EU to continue on this work. And this is a collaboration between several partners in Europe, where the aim is to develop models that can help guide the treatment of the individual CLL patient. So we want to collect both clinical data from patients that have been on clinical trials, functional data similar to what I have shown you, and genomics data, and to use this to develop machine learning models that can hopefully predict treatment outcomes such as toxicity and resistance, and then be used to guide the treatment for each patient. So with that, I would like to thank all the people involved in this study and you for your attention. And I'll be happy to take questions.